It's often said that socialized medicine is a big problem. Those who oppose it say it's a big problem, but maybe more important, during Hillary Clinton's attempt at healthcare reform, many say that the attempt fell apart largely because it was impossible for the Clinton Healthcare Commission to consider what we now call rationing. That it fell apart in essence because it was impossible to do a really careful consideration of how much mental health care, for example, we would provide, how much drug would be provided in certain kinds of situations. And when you finally got to what the state of Oregon and its famous healthcare experiment tried, the problem of trying to come up with something like what Oregon had, a list of diseases ranked by their, let's not say importance, but economic priority, well, what happened in Oregon is instructive. The thing starts because of a problem with a child, an anecdote that was incredibly moving about a child and whether they received certain kind of health care, and it ends with an implosion of the system around a different child who didn't receive a kind of care that they were expecting. National health care reform then, or the social cost of medicine, has developed some really bad words. Socialized medicine is the one that's most often used as a term by those who oppose healthcare reform from one side, let's call it the right side in the United States of the political world. But as I said, it, along with the word rationing, or what some people now, actually most people now refer to either jokingly or seriously as the R word, are so demonized that it's almost impossible to have a coherent conversation about them. Let me go even a step further. Having a conversation about rationing among bioethicists is a bit like having a conversation about abortion in a church where abortion is a hot button issue. It's almost impossible. Now, what does that mean really? Let me make a suggestion. The idea about social cost of medicine has importance for clinical ethics at 3 levels. First, the social cost of medicine bears directly on cases, for example, involving vulnerable people for whom the resources that are available in a hospital will prefigure the ethical options. If you live in Montana, where there are a couple of major medical centers and really only one that has the ability to treat particular kinds of conditions for newborns, and you happen to give birth to an infant who is, let's say, 23 or 24 weeks gestational age, there is no way to get a helicopter to you if you're more than, let's just even say more than 100 miles away, and bring you to Missoula and treat the child such that they will live. And so, in essence, just as is true for heart attacks and a variety of other conditions, there's a kind of rationing, as it were, that takes place because of geography. I can recall in doing a study of healthcare in Montana, looking at rural healthcare ethics. And one of the principal differences between the world that we think of on the East Coast and the West Coast and any city where you have the number of academic medical centers that we, for example, have in Kansas City with 3 different medical schools, is that, look, doctors have 22-mile-long driveways. And there'll be one doctor for 200 or 300 square miles. So in an environment like that, a variety of things go out the window. But among them is the capacity to have a moral conversation about whether or not, or let's just say to have an ethics debate about whether or not you should or should not provide some infant with care because they might or might not benefit from the care, or because it would be appropriate or inappropriate to grant the parent's wishes to it. You just don't have enough gasoline and we don't have a transporter beam, so you can't get the person to the hospital. The second area at which the social cost of medicine becomes directly relevant in clinical ethics has to do with this idea that we have that the units that are created in major medical centers, and for that matter in a variety of different other contexts, are a function of, well, let's just call it legislative decision-making. So, lots of cases that involve, again, newborns, involve, in essence, whether or not it will be possible to provide a certain kind of care to a newborn. But what isn't discussed is whether or not the newborn is able to receive the care before the decision about the ethics of the care is made, because there are or aren't enough beds. And the decision about how many beds there are in a newborn intensive care unit is a decision that's made separately from, or at least should be made separately from, the decision about whether or not a particular kind of care is morally and clinically appropriate. If there are only 5 beds and there are 7 people, then we're back to the earliest decisions in bioethics about how many people can you put in line to get dialysis if you have 2 dialysis machines back in the early 1970s. What do you do if you only have a certain number of organs and there are literally, as there are now, thousands of people who die waiting for them? So-called issues of scarcity present a dilemma that often isn't considered when we talk about cost. And then there's the most important piece of this that, as I'll describe, also really doesn't get discussed thoroughly when we talk about clinical ethics. And so I'm excited that we'll have a chance to talk about it. And that's this idea that you could have a kind of medicine that wasn't socialized medicine. That is, that literally the responsibility of the physician, nurse practitioner, or other primary caregiver is to give the best available therapy, and that anything other than that is rationing, and rationing is bad. It is, in essence, then, possible, it is argued, to have medicine that isn't socialized medicine, medicine that isn't governed by anything other than standard of care. We all now recognize that there's not enough money to provide the best kind of care to everyone. But when it comes to what's sometimes called deathbed rationing, or more frequently bedside rationing, the question of whether or not a patient will receive a particular pill takes on an interesting and important additional valence, right? It's much, much more intense to make a decision about whether or not someone will stay on a respirator, where cost is a real factor for a hospital, because no one wants to talk about how cost matters one anecdote or one case, or to put it in a moral way, one person at a time. So, is it possible to have medicine that is not socialized? Well, to rely on the philosophy that was articulated by John Dewey back in 1922, you could argue that in any system like medicine, there just isn't such a thing as a non-social moral endeavor. When we build hospitals and people come in, we're pretty clear, if they have trauma centers, that if you're injured in a motorcycle accident, you will be treated. An ambulance is always dispatched. And when that ambulance brings you to the hospital, in the emergency room, you just get treatment. And that can cost millions of dollars or hundreds of thousands of dollars or very little. But either way, the cost of that treatment is passed directly through the hospital. And depending on the situation, the size of the hospital, etc., that cost can amount to an enormous burden on the hospital itself, or to an enormous burden on the government, or both. But either way, the cost gets passed on. It's just a simple reality that if an analgesic costs 20 times more when you're in a hospital than it would when you go to a drugstore to purchase Tylenol, the reason is because those costs from the trauma center or from any other unit where people without insurance are being treated results in the escalation of other costs to patients who are insured. That's socialized medicine, Dewey says. Or to put it a different way, it's stupid socialized medicine. And by that, he just means that if you engage in a social endeavor where there are relationships among those who have and those who have not, and relationships between different choosing mechanisms like how we'll set prices versus how we'll understand who has a right to what care, then if we don't think about at all the economic implications of doing one thing versus another, and then develop a global principle about justice in that situation, we've still got a social medical system. We just don't have one that's thoughtful, right? Whereas socialized medicine, as it's conceived also in political settings, that is a plan by a government agency or by even a group that's organized around charity, a planned system of socialized medicine, equally or more criticized simply because it is planned, is, even if it doesn't work very well, at least characterized by forethought. And so when it fails, you can go back and say, this thing went wrong and we should adjust. So there are those who say we shouldn't plan because we can't plan well or because that will result in unfairness. And there are those who say we must plan because at present the health system is collapsing and there are enormous cities with no trauma care, etc. But these three pieces for the clinical ethicist are often ignored because we think of the questions of economics as being not so much outside the sphere of what we think about. After all, justice is a big part of ethics, but outside the sphere of our expertise. Whether you were working on a hospital ethics committee and never took an economics class, or whether you're the most highly trained bioethicist with an MBA, you aren't used to thinking, because it's just not within the core competencies, it's not built into how we think about the discipline, to talk about whether or not someone should receive care in a clinical ethics consult based on money as a deciding or even orienting factor. Now, the allocation of scarce resources is often brought up, but this sort of parsing of words between resource and money makes things more complicated. So what I want to present to you is this idea that there's a problem, that the societal costs of medicine cash out, to use the term of William James applied to pragmatism back in 1910. They cash out, as it were, in a very simple way. One either does or does not take seriously the fact that in some countries we actually design standard of care, treatment modalities, and even which drugs are developed around how much money there is in the healthcare system to support the treatment of illness. And in other systems, such as the United States, we just don't think about it at all. So, for example, it is unbelievably rare to find a medical school that teaches about rationing. In fact, in most epidemiology and biostatistics courses, surveys have shown that it is, in fact, taught that rationing is in direct contravention of what it is to teach good medical practice. So this raises then two questions. One, to what degree do you think that it's your responsibility or within the scope of your authority and expertise to work on questions about the social cost in an individual case or in a policy? And second, to what degree is it your responsibility to educate, to be an active person who is involved with whatever institution you work with, in insisting that the discussions about what drugs are prescribed, what kinds of moves we make in terms of suggesting treatment modalities for example, cancer, whether or not educating that how we expend resources is a moral matter is a part of the responsibility of a clinical ethicist, or whether, in fact, we are to deal with things one case at a time, and perhaps with our blinders on, deliberately, with regard to the economic issues that face us. This is a matter for healthcare economics, but it's also, I think, an important matter for clinical ethics, and I look forward to talking with you about it. Thank you.